As soon as we start, there will be seamless flow. And those of you who are going to be audience, please kindly come forward because we want to engage in a very interactive discussion of the study findings. How are you? Yeah, so you have to choose which one you want to attend. Then you attend. This is the health session. Then up there is genes and something. All right, please come and sit down. Let's start. Presenters, please get ready. Oh, Ghanaian conference. People don't want to come. And let's start. They are eating. Postgraduate students. Postgraduate students, come in, come in. We are starting, please. We are doing conference, they are eating. They are eating. Well, they seem to be saying 11:30. And I'm about 12. Please, we are starting. Come, and let's start. OP, enter. Timo, enter. Please, those presenting, come in, let's start. How do you call them to come in? Yes. There's a little. What mom had a bear? Oh, a bear. Oh, a bear. Manfa bagama. Manfa kaba. Okay, the kaba. Please come in, sit down. Let's start. Manu now on the when things are scoring. Hey, never brought because what's it? Are the presenters in? Presenters, are you in? So we want to encourage all of us to move up front, please. Please, let's move forward so that the presenters can see your face and be motivated. We know it's not easy to do presentation. So thank you very much. Those of you who are behaving as if you haven't heard, please kindly move forward beyond this line. Beyond this line, let's move forward, please. Good afternoon. Are you presenting? Please, the IT person is standing there. So if you are presenting, okay, let's take the first 6. Then in the afternoon, we'll take the... All right, so let's start, because I think that if we don't, we have to sort of be respectful of people's time. It's always important. Some people, they habitually want to sit at the back. When you tell them forward, they will sit at the back. We are saying that those, yes, Madam Yellow, and Mr. Please, beyond this line, all of you come forward so that the presenters can see your face and have vim to present. Please come. Move forward, move forward, please. I didn't know anymore. So be fast. So do we have all the 6 presenters ready? All the 6 presenters are ready. So let's go through the list. We have Helen. Is Helen in? Is Francis in? Francis. Okay, Francis is here. Fortress is here. Elliot is not here. Yvonne, are you presenting today? This morning? No, it's not in the afternoon. We are taking a set of 6 presentations. But afternoon. Afternoon. They're supposed to be 6.
The next page
has the 2. Yeah. So please, Yvonne, please upload your slides. Jonathan, have you uploaded the slides, please? Okay. So we have Helen, Francis, Fortress, Elliot, Yvonne, and then Jonathan. All right, so good afternoon, and then welcome to the oral presentations for this scientific conference. Have you loaded all? Yes, my name is Professor Fred Stephen Safo, and I'm going to be co-chairing this session with my dear brother,
Edward Dasa. Thank you.
All right, so clap for us. It's not easy to become a moderator, so you clap for us more. All right, so the plan is that Each presentation is supposed to be for 15 minutes. And so I think for a meeting like this, we'll do the presentation within 10 minutes and allow for questions. We learn more from the questions than the presentation itself because the presenters have to take feedback to improve upon their work. So if you rehearse for 15 minutes, change it to 10 minutes. Because I'll set an alarm. When it is 10 minutes exactly, the mic will go off. Okay? Can you do that? You can. Very good. So, what I want us to do is, for the next 1 hour, just sit and listen to 6 presentations. And then we'll use the 30 minutes to take questions. Then we'll be out of here. Okay? All right. So, without much ado, is the first presenter ready? Yeah, so some have not come. When we finish and they come, we'll not listen to their presentation, isn't it? And we'll not score them. Scientists are supposed to be disciplined. If you're a scientist, you're not disciplined, I'm afraid. You're not a scientist. We can't. All right, so do we have a presenter who is not coming in? We have 6 presenters. Helen, Francis, Fortress, Elliot, Yvonne, and then Jonathan. Okay. Let's please settle down. Please, nobody should sit behind the cameraman. You should appear in the view of the camera because people are watching online. So they should be able to see you. So if you are behind the cameraman, please move forward. Thank you very much. I know some of us in school, we used to like sitting at the back. But you are now postgraduate, so repent. Come forward. Thank you very much for coming. Please take your seats. I presented for Elliot. Not yet. Please, you should not sit behind the cameraman. My friend, you got up, you were coming, and you've changed your mind. You like the AC? Hey, my brother. There's also breaking protocol. They say, brother, it's AC. Okay, please come forward, come forward, come forward. Nobody should sit behind the camera person. Helen, is Helen here? Helen is not here. Okay, so we'll skip to Francis then. So get ready. Please upload the slides for Francis. Do you know how to move? Where is Francis? Good. Do you know how to move the slides? Those who are going to present, come and let's coach you. Don't come here and then they have to coach you before we start. I see what the like you should see the next slide before. I was saying I'm doing slides no go trim more. So I have presented din baba no go trim. Can now. And the mundi slides no go trim. Ban mama can yako. And so So practice how to move the slides. Have you tried your hands on the slide movement? Let them all try so that they don't. So practice. Good. Next one, practice. Good. Next one, practice. Good. Next one. And then the pointer. Where is the pointer? Hey, where the pointer? Conference, there was no pointer there. So don't be coming in to be doing this. Oh, that's your pointer now. Pointer. Measure up a pointer, Bernard. All right, so I think we'll make a start. So thank you very much and good afternoon. You're welcome to the first session of our presentation. As you realize, we are about 45 minutes behind schedule. And we'll try and make up for lost time. So the presenters will have 10 minutes to present. Please note your questions down. We want this to be very interactive. So at the end of the 4 or 5 presentations that we have, we'll open it up for questions. We'll score the presenters for how they respond to questions. So please kindly help us to do that. I'm here with Dr. Dasa. Dr. Dasa, please introduce yourself. When we started, there were only 5 people. Now there are more people, so you introduce yourself.
Edward Dasa, School of Public Health. Thank you.
Let's clap for Dr. Edward Dasa. All right, so our first presentation is going to be by Dr. Are you doctor yet? Soon to be Dr. Francis Fojo, and he's going to talk to us about incidents of hypertensive disorders among parturients and their treatment practices. Is it? You modify. Hey. I change that then. Okay, let's look at this one. Prevalence, factors associated with and treatment protocols of hypertensive disorders in Bono region. Let's appreciate our brother Francis Fojo.
Distinguished members of the academic panel, ladies and gentlemen, I stand here today to present a topic that impacts maternal health in our sub-region. The subject for discussion revolves around the burden of hypertensive disorders in pregnancy at the lower level health facilities and how the treatment protocols could be optimized to help improve maternal care in the sub-region. I am Francis Fojo. As we strive to contain maternal mortalities in the sub-region, determining the burden of hypertensive diseases at lower health facilities, and then helping to manage these conditions could go a long way to help solve a problem that could improve our effort to get to our targets related to our Sustainable Development Goal 3. So I present on the prevalent factors associated with and the treatment protocols of hypertensive disorders in Bono region, Ghana. I'll be going through the background, problem statement, aim and objectives, methods, result, discussion, and conclusions. Now, hypertensive disorders in pregnancy, namely chronic gestational preeclampsia, eclampsia, superimposed preeclampsia continue to mar the progress of many pregnancies globally, resulting in abrupt delivery interventions, complications, and mortalities with the potential of undermining the Sustainable Development Goals. HDPs have become topical recently because of the increasing number of reported cases and the adverse outcomes associated with them in many countries. The past 3 decades have witnessed a 10.92% rise in the incidence of HDPs worldwide, having risen from 6.30 million in 1990 to 18.08 million in 2019. Now, more than a third of women with HDPs in Ghana experience near-miss episodes, and the ratio of that to death associated with HDPs is around 12:1. Now, despite its negative impact, most studies that search HDPs in Ghana appear to focus on tertiary health facilities with little published data from the lower level facilities. The World Health Organization implicates care plans offered to pregnant women, including HDPs in sub-Saharan Africa. Treatment outcomes using the basic global principles of managing HDPs, typically antihypertensives, anticonvulsants, and timely delivery, have not been encouraging on the subcontinent because of increased maternal mortality associated with the conditions in the sub-region. In post-implementation studies, there were challenges and inconsistencies identified with administration of magnesium sulfate to eclamptic women. It has been suggested that the unavailability of published studies of HDPs in smaller regions affect global and regional estimates, and that misinformed policies thus the need for this study to fill such a gap. Although Ghana has adopted all the basic management principles of HDPs, implementation studies that evaluate same in health facilities are limited, resulting in a knowledge gap to be filled. So the aim of this work is to assess the prevalence, factors associated with, and treatment protocols for HDPs in the Bono region. And specifically, we wanted to assess the incidence of HDPs among parturants in the region, to determine factors related with HDPs, and to evaluate HDP treatment protocols at the hospitals in order to determine their conformity with current practice guidelines. Methods. It was analytical, cross-sectional in design. The setting was hospitals in the Bono region, and there were 9 facilities. The population was liberated women, and our target was parturants diagnosed with HDPs. There were 711 subjects who were diagnosed with those conditions, and the study period was January 2021 to December 2021. Source of data, we had labor registers, treatment protocols for applying magnesium sulfate, antihypertensive to HDP clients, and there was a survey as well. SPSS version 25 was used for data processing and analysis, and the chi-square test with p-value less than 0.05 was used to assess the associations between maternal social demographic factors and the disorders diagnosed. Out of 9 hospitals, 5 were mission-owned. 8 operated at the district level, and in all, there were 16,206 deliveries for the study period. Those diagnosed with HDPs were 711, giving a prevalence rate of 4.3%. Now, parturants aged 26 to 34 years formed the largest majority. And then in more than 60%, or more than 60% of the subjects had no education or they ended at the basic level. And more than half were multiparous women. The commonest HDP was preeclampsia. And preeclampsia without severe features occurred in 30.52%. In 20.96%, it was associated with severe features. Gestational hypertension was among 27.99%, eclampsia among 6.19%. Now, in comparing liberated women characteristics with the hypertensive disorders, chronic hypertension was conspicuous among advanced maternal age multiparity. Preeclampsia with severe features also common among multiparous. Eclampsia was common among those who had low education, and then those who were delivering for the first time. That is primary parity. In determining the associations between partnerant factors and the conditions diagnosed. Now, chronic hypertension was significantly associated with advanced maternal age. Preeclampsia, whether non-severe, severe superimposed, or eclampsia, significantly associated with old maternal age and gestational ages 34 to 37 plus 6 weeks. Preeclampsia with severe features was significantly associated with lower educational status, and eclampsia highly associated with extremes of maternal ages and primary priority. Antihypertensive medications. Now, mitadopa, the 250 milligram and nifedipine 30 milligram were 100% available in the hospitals for managing HDPs. Nifedipine 30 sustained release was first-line agent in 7 out of 9 hospitals. IV hydralazine was 100% available and the first choice for managing hypertensive crisis among partnerant or pregnant women or pregnant hypertensives. It was only in 4 out of 9 facilities who had IV labetalol as well. Now, usage of max sulfate to manage preeclampsia or eclampsia. It was 100% available in all the hospitals. The type of stocks we had, the 50% and the 20%. 8 hospitals had in stock of the 50% and 1 facility had only the 20%. The type of treatment regimen, loading dose only, no facility was doing that. All the 9 facilities were doing loading dose plus maintenance doses. Composition of the loading dose was 4 gram IV plus 10 gram IM, and all the facilities were doing that. Doing 4 grams IV plus 10 grams continuous IV infusion was not practiced. Concentration of max sulfate when given by IV was 20% in all the 9 facilities. Maintenance doses, 5 gram IM 4 hourly, was practiced by all the facilities. Concentration of maintenance doses or max sulfate by IM route, 50%. 8 facilities were using the 50% to administer IM doses, and in 1 facility, they were using the 20%. And we found that that was an issue because for you to inject 5 grams IM using the 20%, you need to take about 25 mils in terms of volume to administer that. And that was difficult to administer, and that was going to cause a lot of problems to patients. Renal function test results seen before starting max sulfates. Always seen, none. No facility always saw renal function before starting max sulfate. Sometimes, so all the facilities sometimes would see the renal function test, but not always. And patient monitoring was solely done by patient signs and symptoms. Serum concentration of max sulfate monitoring, none. No facility was doing that. So conclusions, the prevalence rate of HDPs in Bono region is 4.4%. Preeclampsia is the commonest HDP among partnerants in the region. Lower educational status, advanced and or younger maternal ages, and primary priority are associated with HDPs in the region. The extended release nifedipine oral and IV hydralazine are the mainstay for maternal hypertensives in the region. Max sulfate protocols for preeclampsia eclampsia conformed with the prescribed regimen, except the supply of 20% solution for IM maintenance doses due to its harmful injectable volumes that have to be applied. So we are asking pharmacists, the pharmacists may need to be sensitized on the uniform supply of 50% max sulfate solutions that is more feasible for IV and IM doses under the prescribed regimen instead of the 20% solution. So these are the references. Thank you.
Shall we put our hands together again for him? Thank you very much. So I think we'll finish with all the presentations and take questions. So Francis, you can take your seat. Well done. Okay, so our next presenter is Fortress Yaira Aku. Has your topic also changed? No. So I can read from here. Okay. So she's going to present on effect of mobile interactive voice response systems use among community-based surveillance volunteers on TB case detection in the western region of Ghana. So shall we now listen to Fortress? Thank you.
Okay. Good afternoon, faculty and colleagues. So as mentioned rightly, my name is Fortress Saku, and I present my thesis, which is still work in progress, and it's titled Effect of a Mobile Interactive Voice Response System Used by Community-Based Surveillance Volunteers in the West on case detection, specifically tuberculosis, in the western region of Ghana. And it's under the guidance of this supervisory team, Dr. Amwesi, Professors Quentin Horoff and Deborah, and Doctors Opoku and Deborah. So this will be my presentation outline. So according to the Joint External Evaluation Report for Ghana, the country is still struggling with real-time surveillance capacity, but also that the country has an inadequately functional community-based surveillance system. Then, moreover, tuberculosis remains a public health concern, and the country has been struggling with low case detection over the years. Attempts to address that had seen a number of implementation of interventions, including the introduction of a symptom-based screening tool. But this tool is largely used at the outpatient departments or facilities. So follow-up studies have shown that the tool is inconsistently used, thereby undermining the very purpose for which it was introduced. And so it has resulted in districts still struggling with low case detection. And for example, this graph is for the western region of Ghana, which happens to be one of the top 5 regions contributing high reported TB cases in Ghana. And so you realize that it has inconsistent TB case notification rate, and therefore it means that we still have a problem. However, studies elsewhere have shown that instituting mobile health approaches and other forms of enhanced community-based surveillance systems actually have shown feasibility, and also that it has shown some improvement in the yield of TB cases. And so this forms the premise for the conceptualized study that I am undertaking. And so specifically, I'm looking at mapping the evidence of mobile health tools in use by community-based surveillance volunteers for infectious disease surveillance in Africa. And then secondly, I am trying to assess the effect of a digital platform called the Mobile Interactive Voice Response System used by community-based surveillance volunteers on finding and reporting TB cases in the western region of Ghana. And finally, I will explore the perspectives and experiences of volunteers that will use this tool for further development of the tool. So I'm employing a mixed method approach in 3 phases. And my study population include the community-based volunteers, healthcare workers who are providing TB services, and then the TB records for the period under review. Of the variables that I'm interested in, I have age, sex, community, the lab outcome, among others. And my primary outcome of interest here is the cumulative yield of the positive or confirmed TB cases. And some of my secondary outcomes include the TB case notification rate for the districts of interest, and then the total number of presumed TB cases. So this study is being conducted in 2 districts in the western region, the Takwan Swaya municipality and the Pristia-Huni Valley municipalities. So for the phase 1, which is linked to my objective 1, I have undertaken a scoping review, and this was based on the framework of AXI and O'Malley. So I started off from identifying the research question all through to collating and reporting the results. And the protocol has been published, and I'm finalizing the results currently. For my objective 2, which is the phase 2, I am implementing a 3-arm cluster randomized control trial where 44 communities being referred to as clusters are being randomly selected, and they have been allocated into a 1:1:1 ratio. So in my control arm, I have no intervention whatsoever, where we are just observing the routine surveillance of TB case reporting and notification. Then in the second cluster or arm, where we have community-based volunteers randomly selected across the 44 clusters. They have been provided with a refresher training on TB case definition, and they have been given a TB CV register in reporting cases that they may come across. Then in the last arm, which is the mHealth or the digital platform arm, we have provided the same intervention in addition to empowering the volunteers digitally, whereby apart from all of that they will also report these cases digitally. And so the team is able to visualize through a web-based system whatever is going on. And so this is the mobile platform called the MIVRS. So it basically works on the principle of an algorithm which is based on the traditional symptom-based screening tool that is being used. And so volunteers in this get to just call a hotline that is linked to a computer system, and they follow the voice prompts in reporting presumed TB cases that they may come across. And the team is able to visualize this. So on my phase 3, which is linked to the objective 3, I will use a qualitative approach. And this will be based on an integrated framework, specifically 2 frameworks: the predisposing, enabling resources and needs framework, and the technology acceptance model for resource limited settings frameworks. So these frameworks, integrating them has been found to be useful specifically for what we are doing. And so for data analysis, I'll do descriptive and inferential statistics for my quantitative data using Stata, and the qualitative data will be analyzed thematically using NVivo. So ethical approval for this study has been obtained from the following committees. So as part of preliminary results for my objective 2, we have realized that this is just for a 5-month data. Data is still trickling in. We realized that 19.6%, 57%, and 65.5% of positive TB cases were found in the control, the CBV register, and the MIVRS clusters at baseline. And that at end line, during our study for what we are doing now for a 5-month period, we have recorded 16.2%, 45.3%, and 32.5% for the control CBV register and MIVRS arms respectively. On CBV's contribution to case detection at end line, because at baseline we realized that the district have no record whatsoever of CBV contribution, and the interaction also shows that CBVs rarely contribute to TB case detection and reporting. So at end line, we realized that there was 2.5%, 31.6%, and 42.2% of CBV's contribution to TB case finding and reporting in the control, the CBV register, and the MIVRS arms. And in addition, we realized that being found as a TB case and being detected was 2.28 times more likely if a case was found in the CBV register clusters compared to the control. Again, we found that being found as a TB case and being notified was 2.50 times higher if a case was found in the clusters in the CBV register compared to the control. And combining the effect, we also realized that being found and detected as a TB case was 2.4 times higher if a case was found in any of the intervention arms compared to the control arm. So in conclusion, this is the first study which has sought to develop and test a mobile health tool specifically led by CBVs in improving the surveillance of TB in reporting presumed TB cases in Ghana. And the results at the end of the study will inform further development of the tool, and in addition will inform stakeholders on the possible adoption of the tool to improve on TB surveillance. And finally, the findings will also reveal whether it is feasible to use a community-based volunteer-led mobile health approach in task shifting the screening of tuberculosis cases. So thank you very much, and I acknowledge the following.
Another round of applause for Fortress. Very, very brilliantly done. So we move on. I think we have another presenter who has joined us. So kindly come and upload your slides. So there's Elliot. Helen, is Helen here? Helen. So Helen is no show. Okay. Druzo. All right, so the program outline is on page 18, what we are doing, the oral presentations. We have our third presentation to be given by Dr. Elliot Corantin-Tano, who is going to share with us findings from his work on the impact of COVID-19 on health service utilization in sub-Saharan Africa, a scoping review. A round of applause for Dr. Elliot Tano.
All right, thank you very much, Prof, and good afternoon to you all. So as been mentioned by Prof, I am coming to discuss some scoping review that we have been working on for some time now as part of some work I'm doing. The topic is about the health service utilization basically in sub-Saharan Africa, and it's part of the whole project where we are looking at scoping review and then finally collecting data on the ground to be able to understand what the impact of such a huge thing like COVID had on our health service. And if you would realize, there was a debate as to whether indeed it was COVID that was killing us, or probably the impact of the COVID necessarily. We didn't die from COVID, but we were dying by the fact that people were not getting access to healthcare. And probably that's why the diabetics and all would not be able to. So this is what we are hoping to do, starting from a higher level in terms of what has been done so far, to be able to inform what we'll be doing here in Ghana. So basically, we know COVID-19 has been a challenge globally and in sub-Saharan Africa. And indeed, we are interested in health service utilization. So what is this about? It's a process of seeking professional healthcare service, especially provided in the form of healthcare contacts with the purpose to prevent or treat health. So whatever interaction you have with the health service provider is what we call health service utilization. And indeed, we know that there may have been an impact. Some studies have been shown out there, but we're not too sure what the situation was in sub-Saharan Africa. And it was actually because some scoping review we had seen earlier on actually showed that, studies were done elsewhere, but we didn't find any in sub-Saharan Africa. So we decided to also scope sub-Saharan Africa to be able to inform us. And the aim was to assess all the evidence that we have so far during the pandemic. And then we're trying to find out, did it affect health service utilization, or is this just our mindset that is making us think so? So basically, the idea was to let's cope, because indeed, if we were as confident as we are now after we collected the data, we probably may have done a systematic review, but we decided to scope because we're not too sure what to find. And then again, using the same methodological framework by Askey and O'Malley of 2005. And then we followed the preferred reporting items for systematic reviews and meta-analysis, and then as per the checklist that are provided. Indeed, we're excited to also say that our protocol was also published. So if you need more details on the protocol, you could find it in the BMJ Open. It's an open access journal where you'll be able to find what, in terms of the protocol list that we followed for this particular study. So I don't bore you with the detail. But nonetheless, I'll let you know what the search strategy was, in the sense that we tried to comprehensively capture all the data, of course, from 2019. That is where COVID actually started off, and then up till March of the time that we were doing the study. We targeted the huge or the big databases, that's PubMed, Embase, Scopus, and then Web of Science. And we had three main key concepts that we were looking at. And these key concepts were, one, COVID-19 pandemic, and of course, all its synonyms. And then all the health service utilizations. So some may report it as OPD, some may report it as inpatient care, some may report as blood transfusion, whatever the interaction the person had with the health service utilization. And again, in terms of where are we talking about, Sub-Saharan Africa is where we were focusing on. So who did we include, or what studies did we include, I should say? So virtually any study that is either single study or multi-center would include it. And indeed, because it's the scoping review context, or if you look at it in terms of intervention, whatever we found, the intervention or the context being the COVID-19 pandemic itself, comparator was not really required for this study, but it was interesting to find that there were some studies that actually were comparing to pre-pandemic, which we actually loved because it gives us the benefit of comparison from the pre-pandemic period. And of course, health service utilization being an outcome study, outcome of importance. The time, again, like I said, from 2019 all the way to 2023, and we're interested, and indeed we restricted, our studies to just English and French because it's mainly from Africa. And then we decided, because we're not again sure of what we're going to find, to include both quantitative and qualitative studies in our search. However, if there were guidelines that have been written, or letters to the editor, or recommendations, or protocol papers, or preprints, and conference abstracts, we actually decided. And sometimes you look at the papers and you really not find much, though probably it has a nice topic that captures what we're looking out for. You are not getting the clear data that helps us to analyze, especially the quantitative. We actually excluded them. What did we find? So indeed, we realized that through the databases, we were able to get about 21,440 studies, basically. And of course, there were duplicates that were coming from. So after taking out the duplicate, we were left with about 14,625. After the title and abstract screening, we were able to get out irrelevant studies. That was about 14,000. And that which qualified for full text review were 579. Which ones did we exclude? So we excluded, of course, like I mentioned, the communities and all. And these are the ones that have been put out there. And then basically about 317 were totally excluded. Finally, we had 262 papers that virtually fitted our criteria for inclusion into our scoping review. How did it look like? So this is a pictorial view of virtually what the results were like. So indeed, we're able to get data from 39 countries out of the 46 that were expected in Sub-Saharan Africa. And indeed, you would realize that the deeper the blue color, the more studies that were found in those particular countries. So you'd realize that the very light color is just one study, and then 1 to 5 studies, 5 to 10 studies, a bit deeper, and then the very deep ones, and you can realize Ethiopia, Kenya, South Africa, and Nigeria really had. At least Ghana was not bad, and indeed, one of the papers we scoped was one that was done by Prof. That talked about stroke in terms of utilization within the period. So that was also included. So multi-center studies actually took the center stage about 62%. Most of the studies were hospital-based, and that makes a lot of sense because that is where people were. But of course, we also saw some community-based studies. In terms of urban, peri-urban, and rural, of course, I mean urban because COVID was more in urban areas. And the the studies that actually reported numbers in terms of participants were able to put together, and on the average, the median participants were 836 in terms of the numbers that were included in the study. And again, the majority were outpatient, and the inpatient followed. So in terms of study design, like we thought, the quantitative were superior, and again, that gave us some leverage to be able to look at some quantitative data to see whether we could try and put them together to come up with a median in terms of the percentage reduction in health service utilization during the pandemic. But however, about 15% of them were qualitative studies indeed. It is out there because we didn't dig deep into the qualitative, but I think it's also another that we can look at, because just looking at some of those papers were very, very interesting papers that we need to get some information out of them. And there were some 1.4% of the studies being mixed method studies. In terms of the disease distribution, which again, very interesting, we looked at communicable diseases, non-communicable diseases, the ones that were reporting both communicable and non-communicable diseases, injuries, preventive health, and there were some that they just came for blood donation and so on and so forth. We couched there as the others. And indeed, communicable disease was the majority. It wasn't too high as compared to the non-communicable, but the HIVs, of course, the TB clinics and all, these are inherent clinics in some of these studies. And we realized that it was easier for them to be able to conduct such studies because they already have pooled data sitting there. So within the COVID period, they were able to just compare and realize that maybe their numbers had either come down or gone up, which we are going to talk about very soon. Which patient group? So like I've already alluded to, so people with HIV, tuberculosis, maternal and child health studies, sexual and reproductive health studies, and that which talked about only child health, inpatient, outpatient. So these were distributions in terms of the kind of cases that we had. But interestingly enough, maternal and child health were really, in terms of patient group, was actually the higher. So the moment we saw there's some other masters, MPhil students or masters has actually tried to look into the maternal and health just to try and find out whether they can come up with a systematic review. So virtually all the huge numbers, meaning that there's some data that is sitting there that we can look at looking forward to be able to address the concerns of health service utilization in these patient groups. Thank you. All right, so in terms of those that reported, so these are the core of the studies, the majority, 85% or about 85% actually reported decreases, which is actually what we expected. But interestingly enough, about almost 10% actually reported some increases. Others reported no change in health service utilization. And this is actually the summary slide of what, in terms of the quantitative that we put together. So that reported change was about 32.1% change in health service utilization. In looking at the decreases, it was about 35.6%, and then, like I said, some studies reporting increases of 16.2%. So, and indeed, when we looked at those that actually accumulated the numbers in terms of the decreases, it's actually cardiovascular disease. And for me, this was really telling, because these are the same people we say were dying more from COVID. Is it really because they died from COVID, or is it because probably they were not able to access health care and they were sitting at home because hospitals had closed up and all of that, and that is why they were dying? So this is telling. And rather, infections were a bit on the low, because they will come anyway when they get their cold or their malaria and all, and they won't wait. But then the people with cardiovascular diseases might be sitting at home, and probably that didn't augur well for them. So in conclusion, there's been a lot of studies actually showing that there's been decrease in health service utilization, but the policy implications are the fact that there are still knowledge gaps. You can realize there are some countries in Sub-Saharan Africa where there are no studies. Again, some of them were low-quality studies, but we think we need to strengthen our health service in terms of strengthening the health systems, and then that would help. So when you have a COVID or any other impact, then it doesn't hit you that much. And like I've mentioned through, I think we'll probably need some systematic reviews and meta-analysis in some of these particular groups that have been mentioned. So I would acknowledge these, my supervisors, and I would want to thank you very much for your time.
Okay, so very well presented. Shall we give him another round of applause? So our next presenter is Anna Nkwati Yvonne. and she's presenting on association of BPH severity and dyslipidemia among Ghanaian patients. Yvonne?
Thank you very much, Prof. Good afternoon, everyone. Like Prof said, my name is Yvonne Ananquote, and I'm presenting on association of benign prostatic hyperplasia severity and dyslipidemia among Ghanaian patients. Benign prostatic hyperplasia is one of the most common urologic disorders that affect aging men, and it is non-cancerous. It's mainly associated with LUTS, or lower urinary tract symptoms, mostly frequency of urination, urgency, nocturia, straining, and more. It has been observed that the transitional zone, as indicated in the picture, contributes 100% to the BPH development. BPH impacts negatively on affected patients and place a very significant financial burden on them. Globally, it is observed that at the age of 70, 70% of men could suffer from this condition, and 80% at the age of 85. In Ghana, it's been observed that between the ages of 50 and 74 years, 62% of men suffer from them. A community cross-sectional study conducted also indicated that 27% of the participants had BPH. Genetic predisposition and dietary factors, as well as hormonal imbalance, have been mentioned to contribute significantly to BPH development. However, lipid transport abnormalities have also been implicated. So there are informations on this, it's scanty, and most of them are also inconsistent. So we went ahead to indicate that there's no association between dyslipidemia and BPH. And the aim of this study is to investigate the association between BPH severity and dyslipidemia. We assessed the baseline of the participants, and we determined their prostate volume and PSA levels, and then we evaluated their lipid level as well. The study considered case control as an approach for this. 200 participants were recruited, 100 controls and 100 cases. The cases were clinically diagnosed BPH patients presenting with LUTS between the ages of 50 and 85 years. They are supposed to come fasting. So those who did not fast and those outside the age range, and then those who didn't consent were excluded from the study. This ethical approval was obtained from this institution as well as Ghana Health Service. And then participants were allowed to sign informed consent before they were added to the study. The samples were taken from 2 centers, Lekma Hospital and Rage Hospital. On the arrival of the patients, we allowed them to sit down for some time, take rest, and then their BP and BMI were measured. After that, they answered questions on LUTS, the IPSS questionnaire, and few questions on their meat intake, that's the dietary aspect. After that, 3 meals of blood samples were taken from the patient, transported to the lab, centrifuged and stored at -80. And the same patients, their prostate was scanned, the abdominal scan was done, and then when it was ready to do the analysis, we took the spectrophotometric method and then the ELISA method for PSA, as well as spectrophotometric method for the lipid profile analysis. All the data that was obtained were kept or stored in Excel and then transported to GraphPad programs for the statistics. So T-text for students was used to compare the two groups, and then we used frequency table, and Spearman correlation was used to determine the association. P-values below 0.05 were considered statistically significant. With the baseline of the patient, it was observed that their age, BP, and BMI they are similar, so there was no significant changes. But the waist to hip ratio appeared to be a bit wider for the patients than the controls. It was also observed that the meat consumption of the patients is lower compared to their control counterparts. We looked at beef intake, pork, mutton, and then we looked at chicken and fish. Looking at the whole trend, that's for the patients were lower. And this could be that they might have realized the condition in which they are, so they are cutting down their meat intake, since that has also been implicated. It was also observed that their IPSS level, quality of life, PSA, and BP, prostate volume significantly increased, which means they are not very comfortable. And this is very consistent with work done by Sihan and Ebe. They also realized that BPH patients have increased concentration of prostate volumes and PSA. We further observed that 52% of the BPH patients had severe LUTs, meaning that they have difficulty urinating, compared to 6% of their counterparts. Even those that had moderate LUTs were 35%. Looking at their lipid profile level, it was observed that the lipid concentration of the patients was significantly low compared to that of the control. And this could be because the control group were taking much more meat than the patients, or the patients were taking medications that were lowering the concentration of the lipid profile in them. And this observation is inconsistent with work done by Sehab, Amma, and then Hanjen independently. They all reported that BPH comes with increased concentration of lipid profile. We further went on to look at the correlation between the IPSS, which is the LUTs, and then the lipid profile. And it was observed that there was significantly negative correlation between the IPSS and then the HDL. This was also mentioned in work done by Pearson et al. He found out that there's no association between lipids, but this work is indicating that there is an association with the lipids and the IPSS concentration of the patient. And this is inconsistent with the work done by Pearson et al. We further observed that prostate volume has a negative correlation significantly with the lipids, especially the HDL. Meaning when the HDL level is reducing, the prostate concentration, the prostate volume will increase. And this is consistent with work done by Sihan et al. Sihan and Eber. They saw that the HDL concentration actually has an association with lipids. We therefore conclude by saying this work indicates that decreased levels of HDL is significantly associated with BPH severity. And further went to say that the reduced HDL concentration significantly correlates with the prostate volume, as indicated from the study. And this may be one of the risk factors in BPH development for Ghanaian men. Limitation. This study was just two centered, LECMA and then Rage Hospital. So we could not exactly say that it is representing the entire Ghanaian population. So further work has to be done in more centers. And then we should also look at larger cohorts than the 200. And then we can also look at further dietary factors that contribute to the BPH development. I say thank you to my supervisors and all the others there. That's the reference used. Thank you.
Very well done, Yvonne. Another round of applause. Excellent. So we have our final presentation. So please get your questions ready, because we want to be as interactive as possible. So all the presenters should have at least one question, so that we can score them, because there's a part for scoring on question response. They say they beg, don't be merciful on them. So write down your questions so that we can learn from the answers to the questions. So the final one is by Jonathan Mauto. The surname, I don't want to butcher it, so I won't mention it. Jonathan is here to talk to us on the factors associated with excess mortality in healthcare facilities during the COVID-19 pandemic in Ghana. A round of applause.
Thank you. Good afternoon, faculty. Good afternoon, dear colleagues. So just as you rightly mentioned, I am Jonathan Manyami, and I present on, this is part of the overall research that I'm carrying out, factors associated with excess mortality in healthcare facilities during the COVID-19 pandemic in Ghana. This is going to be my presentation outline. It will start from the background right to the acknowledgement. During the COVID-19 pandemic, all screens had the tally tables recording the deaths and the number of cases. And all around the world, nations implemented several interventions, such as lockdowns. And some of these interventions had in themselves an intrinsic potential to lower the number of deaths. However, these same interventions by themselves equally might have increased the number of deaths, such as factors which might be due to inability to receive timely medical condition. In developing nations, FAT et al. In 2020 reported that 21% of the pandemic's death toll was directly due to the COVID-19 virus. However, there have been questions about the credibility of what is actually a COVID-19 death, because during the heat of the pandemic, there were records of underreporting. The definition of COVID-19 death alone was an issue. When someone dies, is it the primary cause that we record as COVID-19, or the person might have died of hypertension but might have had COVID-19, and therefore what actually killed the person? There were issues of low testing capacity. Hence, considering all these points, it becomes an issue to say the number of deaths due to COVID-19 is this, as far as policy making is concerned. So with all these points in mind, excess mortality, we believe, provides a more realistic assessment of the total mortality impact beyond just COVID-19 deaths. Wag et al. In 2022 defined COVID-19 to be the gold standard when we want to look at the impact of a pandemic on mortality. So the question now is, what then is excess mortality? excess mortality, according to the World Health Organization, in the context of COVID-19 is when we look at the all death that occurred minus the expected that would have occurred if there was no pandemic. Hence, it measures the combined impact of the direct cause of death, which is COVID-19, as well as the indirect, which might be socio-economic factors on deaths. So the study objectives on this topic, the first is to estimate excess mortality during the COVID-19 pandemic in Ghana, and the second to identify the drivers of excess mortality during the COVID-19 pandemic in Ghana. A secondary data analysis was employed in conducting this study. It was a comparative study using two different time points. Pre-COVID-19 pandemic, we considered 2015 to 2019, and the intra-COVID-19 period, 2020 and 2021. To be able to estimate the total number of deaths that would have occurred if there was no pandemic, I used the moving average modeling technique to determine the expected deaths that would have occurred in 2020 and 2019 if there was no pandemic, so that I'll be able to estimate what excess mortality will be. So excess mortality, therefore, is the observed deaths during the pandemic minus the expected that would have occurred if there was no pandemic. For the data sources, I considered the DAMES, the Birth and Death Registry, and the 3 HDSS sites in Ghana, Dodoa, Navrongo, and Kintampo. But for this presentation, I'll present on the DAMES because of time. So these preliminary findings, the DAMES, this is an aggregate data at the regional level. Linear regression model considered. Statistical significance was considered at a p-value of less than 0.05. So during the COVID-19 pandemic, right from 2015 to 2019, pre-pandemic, when you look at the 2020 and 2021, the light blue would have been the expected if there was no COVID-19. But clearly, when we see the observed deaths, in Ghana, there was excess mortality. Again, this is to allow comparison among the regions per 100,000 population. Again, we see that in 2021, more excess mortality was recorded as against the year 2020. A much clearer graph follows. So maybe let me talk on the negative or less than 1. So in estimating excess mortality, we have negative excess mortality and excess mortality itself. So negative excess mortality refers to when the actual is lesser than what would have expected if there was no COVID-19. So again, in 2021, we realized that 5 out of the 16 regions in Ghana recorded negative excess mortality. However, in 2021, more deaths occurred. That was either due or not due to COVID-19 itself, as earlier explained. Moving to the drivers of excess mortality, in both years, 2020 and 2021, population size, urban setting, household population, population density, and number of households were statistically significant with excess mortality. Healthcare system factors, COVID-19 deaths, and number of doctors to 1,000 population was associated with excess mortality in the year 2020. However, in 2021, non-COVID-19 deaths resulted in excess mortality and also the number of doctors per 1,000 population. For non-pharmaceutical intervention, in this context, I considered lockdown. Using the analysis from the Flow Minder from Vodafone, they showed the change in the number of trips between any two districts in Ghana. Again, this is Vodafone, so the question will be, not every Ghanaian uses Vodafone, but at least it points us to what the picture was during the pandemic. So in both years, 2020 and 2021, lockdown had a significant impact on excess mortality in Ghana. In conclusion, overall, the observed number of deaths were higher than the expected deaths during the COVID-19 pandemic in Ghana. In 2020, excess deaths were observed in 11 out of 16 regions, while in 2021, 12 regions recorded excess deaths. These are preliminary results and only include deaths recorded in health facilities. So further studies will be conducted, and it's actually ongoing, where we are looking at the 3 HDSS sites that considers deaths that occur even outside the health facility. So further analysis is ongoing, even at the DIMS data source at the district level, to identify the drivers of excess mortality in Ghana. The policy implication of this study. The findings of this study will go a very long way to help us understand the effect of COVID-19 pandemic on mortality in Ghana. This will help to inform the design and implementation of interventions and how to measure these interventions during outbreaks. And finally, it shows regional variations and to help understand the epicenters of the COVID-19. These are the references I used at the background. I would like to acknowledge KNUST, Global Health and Infectious Disease, KCCR, and GWAC for making this work possible. Thank you.
Very well presented. Shall we give him another round of applause? And let's have a big round of applause welcoming all our presenters on stage. All our presenters on stage, please. A bigger round of applause as they come. So I'll do this together with Steve, and maybe we'll take 3 questions at a go, and then
so just shoot
answer.
your hand up. 1, 2, 3.
Okay, my question goes to soon to be Dr. Fodro. In his presentation, he said the study population was for laboring women. Could you talk about it more? Is it about? Did you consider their gestation? That was not too clear to me.
Okay, so my question goes to Yvonne. In your presentation, you mentioned the fact that the prostate volume was utilized. But then there are different methods of assessing prostate volume. One gives you a larger figure as compared to the other. So I wanted to know which measurement technique was used. And also, did you consider the presence of intravesical prostatic protrusion, since that can also cause LUTs, even in the absence of BPH? And then lastly, how was the severity of BPH? How was it determined? Is it just the clinical findings, or the imaging findings were also taken into consideration? Thank you.
My question goes to Yaira. One of the major problems we have has to do with incentivizing community-based surveillance volunteers to do their work. We are trying to pilot or research into using mobile technology for notification of TB cases, and they may be required to use some data or credit. How sustainable would this be, since the major problem is how to incentivize community-based volunteers? Secondly, how are you able to manage all your supervisors so there aren't confusions? Thank you.
Okay, so thank you very much. We'll take these sets of questions, answers, then afterwards we'll take another set of 3. So who will start? Francis. The first question was, sorry, I give that to you.
Okay. The subjects were women who were delivered. Those who were delivered. Yes. Those who were due for labor and were delivered. Pregnant women who were delivered.
So they finished delivering. Okay, so
Postpartum.
Postpartum. Okay, postpartum. All right. Okay. Next one.
The next.
The severity of BPH I used the International Prostate Symptom Score. It's a questionnaire that answers questions on LUTs. How frequent the person urinates, whether the person strains or there's nocturia. It is put into scores. Between 0 and 7 is said to be mild. And then from 8 to 19 is moderate. Then 20 and above is said to be severe for LUTs. So that's what I used. And then the question on the prostate size. We have the prostate size and then the prostate volume. The prostate size appears to be bigger. So I used the prostate volume to determine the scan. Please, I don't think, have I answered your question, please?
It's here. Thank you very much. So,
Intra something protrusion. Intravesical protrusion. Is it a sonographic? Is your study a sonographic study or chemical pathology study? So Ben, this one is a chemical pathology, not a.
So the last one.
Thank you. So to the first question on sustainability, a number of studies have explored several strategies. And in some of these studies, they have actually put these volunteers on salary. So that makes it very, very expensive. In our case, we are using performance-based incentive and not a huge salary. So that at the end of the day, if the NTP buys into this, sustainability, particularly in terms of salaried community-based volunteers, will not become a major problem. There are other calls for a review in terms of putting community-based volunteers on salary, and that's at the WHO level, which is still work in progress. However, I can also tell you that sometimes interaction with the volunteers reveal to you that they are not so much interested in salaries, but other forms of enablers. So we are coming up with a follow-up study in our qualitative study, which will reveal all the motivation behind those that participated very well and those that did not fully participate. And all of that holistically will reveal to us in terms of sustainability, whether they are interested really in salaries as in terms of monies or other forms of enablers which can be sustainable. In terms of the second question, how am I able to manage my supervisors? Well, all I would say is that it's important for you to try to understand each supervisor. If you understand them, you are able to draw a commonality between them. What brings them together? Or what is that striking force that brings them together? And in terms of scheduling meetings, you need to use the doodle so that everybody feels respected and involved. And constant reminders is also a plus. You don't have to wait so much to the deadline in order to invite them because already they have so much on their tables. So at other times, you may not get all of them on board, and you will have to be able to navigate around that. Thank you very much.
Thank you.
Next well done. So we are moving on. Some people, hey, we've crossed this line. We are going back. Okay, let's take a question. So we are going upwards.
Oh, I thought we're taking 3.
Okay. My question goes to
2,
Dr. Tanner.
And then last.
I would like to find out why you chose a scoping review over a systematic review. Because looking at your topic, it has the potential to impact policy. And in scoping review, specifically the methodological framework by Axe and O'Malley, critical appraisal of the studies you included is not required. So is it not possible that you included low quality studies that can mislead policy?
Okay, so my question is to Yvonne. I think with the lipid profiles of your participants, you considered the diet. I also want to find out if you considered if they were on any form of lipid-lowering agents.
Thank you. My question goes to Aku. It has to do with the results for the baseline and end line. We realized that the percentages were much higher for the baseline compared to the end line. If you could please speak to that.
Okay. We should take more. Steve, we should take more questions. Okay.
My question goes to Francis. Your study used to look at the prevalence, but in your conclusion, you made us aware the prevalence rate was 4.4. How relevant is this prevalence in relation to your study?
All right.
The presenters, I hope you are noting down the questions.
Down.
So maybe after this one, I'm sure we'll take responses. Otherwise.
Please, my question is to Yvonne. Yes, you said you did 100 to 100 controls and cases. So, firstly, where were the controls coming from? Were they from the hospital or from the community? And then also, you said you used age to do the matching. So, aside age, what about the other factors? And why did you do only one-to-one matching and not one-to-multiple matching? Thank you.
Anybody? So 5 questions so far.
Yeah, thank you. This goes to Jonathan. Yes, I want to find out why did he decide to use Vodafone and why not MTN, because MTN seems to have a larger coverage than Vodafone. Yeah, thank you.
Any other? All right.
So my first question goes to Dr. Elliott. You mentioned that you included French articles in your selection. So did your search criteria or the keywords you used in the search included, a translation into French in order to be able to include the French articles? And to Joe, I realized from your methodology that you used univariate linear regression model. Why didn't you consider a multi-variable linear regression model, since some of your variables could interact with each other? Thank you.
Any?
Thank you. My question goes to the one who presented on preeclampsia. In one of the slides, you stated that there wasn't enough guidelines regarding serum levels of magnesium prior to magnesium administration. Would you consider it a recommendation as to adding it to the guidelines to monitor serum magnesium levels prior to MAC-SOF administration? Thank you.
Yes, thank you. Mine also goes to the preeclampsia presenter. You mentioned that some of the facilities, I think 0 of them didn't have renal function before the magnesium sulfate, but your recommendation, you were silent on that.
Any more questions?
So mine goes to Yvonne. During your when you were answering the previous question for the first time, you mentioned making reference to a questionnaire that included questions about urinary frequency. And I want to ask, did you check for confounders like alcoholism among your participants? Because alcohol is known to inhibit the antidiuretic hormones, thereby increasing urine output. So did you check for those confounders as well?
All right. Thank you very much for... So clap for yourself. You asked very thought-provoking questions. Are you hungry? Clap for yourself too. Clap. All right. So Who didn't get a question? Everybody got a question. All right. So the last time we started from here. So let's start from those who haven't spoken.
All right. So thank you very much for those two using profs were thought-provoking questions. Yeah. Why not a systematic review? I think I mentioned it somewhere along the line, in the sense that because of what had already been done, we were a bit concerned because there was one that had just been published where they didn't find much in sub-Saharan Africa. So we're not too hopeful in terms of our search. So we decided to scope to hopefully get a bit more, right? So of course, I mean, if it's scoping, then it's not, as tight as you would want it to be so far as research is concerned. But now we are informed, and again, that's why I mentioned that because of what we have, chances are that at least if we decide to do a systematic review, even targeting particular patient groups, chances are that we might be able to come up with something more. So this is one that is more to like be the John the Baptist in the area. Then we are now able to know that since there are studies available, and I believe there are more now, we will be able to do a systematic review. And I think there was a question that came from the back about the inclusion of French words. Yes, unfortunately, we were, of course, English biased, and we decided to do English. But I think what is clear in most of these databases is that even if it's a French study, abstracts are actually put out there in English. So we did not use French keywords, we just used the English keywords. But nonetheless, we're able to pick a few French studies. Unfortunately, in the final included 262, there were no French studies that were included. But definitely there were some that were in the analysis, sorry, not in the analysis, but that were in the earlier searches until the final exclusion took them out. But we'll take note, and looking forward, we'll probably use French keywords. So for those who would want to continue with the systematic review, please, let's remember to use French keywords. Thank you so much.
All right, sure. Thank you so much for the question. I think for me, the first was with why did I use Vodafone and not MTN? So at the time of the COVID, Vodafone had a contract to also look at the number of change in trips per region. So because they already had that data, I had to just leverage on that existing data just to pick it and run for this study. But then I acknowledge that most Ghanaians use MTN, but at the time, MTN didn't have this data readily available for our use, even though we contacted them. I think the second one has to do with why didn't we do a step-down analysis. So what I presented was a preliminary finding. That is being considered, and also we'll even, from the regional level, we'll go to the district level and also run the analysis as to find out what actually influenced excess mortality in Ghana. Thank you.
When I was listening, I heard moving average modeling. What is that in layman's terms? Sorry.
Okay. Thank you for that. In fact, I expected this question. So the moving average, in fact, there are quite a lot of techniques. We have the auto-regression modeling techniques. But then out of all these techniques, the one that favors when you want to predict the expected in a very short time point, then the moving average is the most appropriate. However, what it does is that it averages all the years you are considering and predict into the future what it would have been if there was no COVID-19 in the context of my study. Thank you.
Did you understand it? All right. Okay.
Yeah, thank you. So as I rightly mentioned, I'm still in the field, and we are still gathering data. So the baseline data is data that has been captured by facilities or clusters that we are working in their hard copies, what we have captured. But for the end line here refers to the intervention phase for our study, and we are still in the field. So data keeps trickling in every other day. So what I have just presented is what has been available before this conference, and we are still in the field. Thank you.
Thank you for the question. The question on alcohol. Yes, I did take data on alcohol, exercise, and a lot more. But because of time, I couldn't present all the data here. And then with the controls, I sampled from the community by screening the community people who consented. And the lipid lowering agent, that was also considered. But as I said, because of time, I couldn't present all the data here. And I have to mention that this study is still ongoing. It's just one part of my thesis. Thank you.
Yeah, there was a question on the significance of the prevalence rate. I mentioned 4.4. Now, when you compare that to a previous study that was done around 2016 by Antwi et al., they found 6.1% in Greater Accra and about 3.2% in the Upper West. So 4.4 was significant. But I couldn't say it was low because I didn't know the national prevalence rate, so I couldn't compare that. Then there was an issue of max sulfate, serum max sulfate not being monitored in the facilities. Yes, none of the facilities was doing serum monitoring. And this had to do with the excretion of max sulfate. Max sulfate is solely excreted by the kidneys. So it is expected that if there is a renal impairment, then repeating the doses would have been a problem. But the protocol also says that the loading dose has to be given regardless of the renal function. So it's subsequent doses that you need to monitor. In the absence of serum monitoring, urine outflow, facilities were doing urine outflow. So if a patient was doing about 30 mils of urine per 1 hour, then it was okay to continue to give the max sulfate. I didn't conclude on that because it wasn't a specific objective of the study. Then there was a third question I didn't get in the middle there.
What question was that? The kidney function. He said he wanted to find out why. Yes. What's your recommendation based on the fact that they didn't have renal function tests? Okay, you sit down. I'm about to ask a question on that. So, all the presenters have 2 minutes to respond to this question. What would be the health or clinical implication of your study findings? Health or clinical policy implication of your research findings? You have 2 minutes to respond. Don't type anything. Put your phone down. 2 minutes. Health or clinical policy implication of your study findings?
Yes. Pharmacists in their supply of anticonvulsant to manage HDPs, we want to be consistent. Supply the 50% because Ghana applies the prescribed method of administration of max sulfate. So supplying the 50% makes it easier to administer the drug either by IV or IM instead of supplying the 20%. So the medical stores in the countries would have to be notified of this so that managing HDPs become easier by the midwives.
So let's clap for him. He's done well. Elliot.
So I think as per my study, the health implication is the fact that one, we need to have a resilient health system. I mean, to be able to manage generally, I mean, what we would consider as our day-to-day clinical care. But then you need a more resilient health system. So when you have things like COVID-19 or a pandemic coming in, to be able to ensure that people don't die, probably not necessarily from the pandemic, because we believe that the numbers of death were not necessarily from the COVID itself, as per the numbers are showing, but just maybe our health system not too great. So I believe that now we have some study to show that, listen, our health systems are weak, one, and then two, to be able to ensure we have a resilient health systems, our policymakers need to ensure that where we have pandemics or when we have, external factors, we should be able to manage them. But if you don't, then chances are that you might lose your people, not necessarily from the pandemic, but then because they were not just able to access the health system. Thank you.
Policy implication of your work.
All right, sure. Thank you so much. So, in as much as we are preparing for outbreaks and possibly future pandemics, when we are implementing policies, we should look beyond just stopping the spread, which is very important, but we should also look at how it affects other disease conditions. So by effect, we can take advantage of telemedicine, where even people at home can equally have great deal of health delivery, even from their various homes. Thank you.
Thank you. I think we should take a second look at the medications that we use to treat BPH. Some of them affect the lipid concentrations with time. So there should be a policy to provide medications that will rather increase HDL concentration for such patients. And then secondly, too, we should encourage patients to take diet that has high concentration of HDL in order to reduce the prostate volume. Thank you.
Thank you. So to achieve the NTB strategy, I think that having an improved TB surveillance system is very important. And more so if we can leverage on the existing community-based surveillance system and enhance it with a mobile health approach to be able to see what is happening at every point in time. I think that will go a long way. Thank you.
Yes, so another round of applause for all our presenters. You can please take your seats. We'd like to thank you all very much for being active participants of this session. I think the next session would begin after lunch, I believe. Or you want us to continue? You want to go for lunch? You've just been told that HDL and prostate, you are going for lunch. So only the females are allowed to go for lunch because we didn't talk about HDL and other things. The males are under 40s, they can go. All right, so we'll meet here after lunch. Thank you all very much. A round of 2:30. A round of applause for yourself. And thank you, Dr. Dasa, for soon to be Professor Dasa. Next week is happening.
Thank you also, Steve.